Internal resorption of multiple posterior teeth in a patient diagnosed with hyperparathyroidism, a case report. Internal resorption has relatively rare occurrence. Its etiology is poorly understood. This case reports the management of internal resorption in multiple posterior teeth diagnosed by CBCT imaging in a patient with end-stage renal disease. A 64-year-old man was referred to evaluate and treat multiple posterior teeth with internal resorption. His chief complaint was pain from a partial crown root fractured left mandibular second molar and a fractured left maxillary second premolar. This patient had no known history of trauma, chronic pulpitis, feline virus infection, tooth autotransplantation, or orthodontic treatment, which are predisposing factors for internal resorption. Dental diseases were absent and oral hygiene was adequate. His only remarkable attribute was a history of chronic renal failure and secondary hyperparathyroidism. Panoramic and periapical radiographs from 2018 and before appeared normal until a crown root fracture in March 2020 revealed internal resorption. Upon presentation in April 2020, 11 teeth were diagnosed with internal resorption. All molars responded to cold and electric pulp testing that confirmed pulp vitality with underlying internal resorption, except for the left maxillary first molar that had previous endodontic treatment. 2 premolars and 6 molars with internal resorption were planned for non-surgical endodontic treatment and crown restorations, while the second molar and premolar that had a crown root fracture are planned for extraction. However, replacement with implants was inadvisable because of osteoporosis. The root canal treatment of molars was carried out over 2 visits with calcium hydroxide dressing in between, while premolars were finished in single visit. All the 8 teeth were restored with the crowns. Extracted third molar with internal resorption was submitted for histological analysis. The inflammatory infiltrate consisted mainly of lymphocytes and histiocytes with scattered mast cells and neutrophils. The dentin surface was devoid of an odontoblast layer and instead lined by a row of odontoclasts occupying resorption lacunae. These multinucleated giant cells were found sparsely within pulp tissue and accompanied by putative mononuclear odontoclast precursors. Scanning electron microscopy of dentin walls shows surface irregularities from various depths of resorption lacunae. Immunohistochemical analysis revealed dentin wall lined with odontoclasts that showed diffuse cytoplasmic staining for tartrate-resistant acid phosphatase resembling osteoclasts. Root resorption, like bone remodeling, may have been affected by hyperparathyroidism because systemic conditions involving thyroid hormone and corticosteroids have been shown to affect orthodontic tooth movement and stability. In this patient with hyperparathyroidism secondary to end-stage renal disease, there were numerous multinucleated giant cells along the dentin surface and within the pulp tissue, suggesting that these osteoclast-like cells play a significant role in internal resorption. The multinucleated cells morphologically resembled osteoclasts found in a brown tumor, the most characteristic oral manifestation of hyperparathyroidism. These cells stain strongly for TRAB, suggesting their resorption of dentin was like that of osteoclasts in bone. Therefore, parathyroid hormone that stimulate osteoclast resorption of bone may have also promoted odontoclasts and their precursors in dental pulp, leading to internal resorption.